Welcome everyone to this podcast on transitions in care with Dr. Silversweig, who is currently the Chief Medical Officer and Vice President for Dialysis Services at Rogosin Institute. He's also the Professor of Clinical Medicine at Weill Cornell and the Medical Director of Hemodialysis at New York Presbyterian Hospital and Lower Manhattan Hospitals. He's heavily involved in education as the Associate Program Director for Internal Medicine Residency and Nephrology Fellowship programs at Weill Cornell. We are very grateful that we have Dr. Silversweig with us to discuss how we could have safe transitions between acute kidney injury and dialysis, between chronic kidney disease and dialysis, and from his perspective of leading a dialysis organizations, what could organizational leaders and physicians could do to have safer transitions. So thank you very much, Dr. Silversweig, for taking time to having a podcast with us.
Well, Dr. Chopra, I greatly appreciate the very warm introduction, and it's a pleasure to be here with you today. I think these are incredibly important topics that we don't talk about often enough.
Thank you. I think we'll just jump into some questions then. CKD to end-stage kidney disease is a very important transition point. And what steps do you think providers can take to reduce the risk for infection amongst these patients, or preventative measures to reduce infectious complications amongst dialysis patients?
So we all know that catheters are the single biggest risk factor for infections among patients treated by dialysis. And far too many patients in this country start dialysis with a catheter access. I think that the latest numbers from the USRDS are around 80% of patients starting dialysis start with a catheter. And that's clearly very, very bad for patients and greatly increases the risk of infection, as I say. So I think that the biggest thing that we as providers can do is educate our patients. It's very difficult for patients to accept that they're going to need dialysis. And the best thing that we can do is intervene early. Our program has an interdisciplinary program where we work with nurses and social workers who often can get patients to understand things in ways that we as physicians or advanced providers cannot. And so we find that the nurses go along, and the social workers too, go a long way towards getting patients to accept the need for dialysis. And that makes it much easier to get them to accept a permanent vascular access. Again, we know that if patients are treated through fistulas or grafts, their rates of infection are much lower. So I think that's the biggest thing we can do is patient education.
And thanks for bringing that up, because in Virginia, central tunnel catheters are the most common access associated with bloodstream infections. And we always have these barriers or challenges on how to overcome reducing our tunneled catheter start rates in dialysis units. So are there any comprehensive educational programs that have been adopted by Rogosin Institute that have led to this smoother transition, or at least reduced your catheter rates in dialysis units?
Yeah, so our program, we call the Program to Educate Patients with Advanced Kidney Disease, or PEAK. And as I said before, it's an interdisciplinary program, and we try to get all patients with stage 4 CKD to enter the program and to meet with our social workers and our nurses, who then really sit with them, and they spend time that we as physicians certainly don't have. So the nurses will spend an hour with the patient, educating them about the disease, the fact that it's advancing, and the fact that they will need renal replacement therapy, and then talk about what those options are. And if the patient doesn't have a strong option towards home dialysis, the nurses will really encourage them to get a permanent access, again, a fistula or a graft, so that we're able to reduce the proportion of patients starting with catheters. And we've been successful at getting our numbers down so that only about 40% of our patients who start outpatient dialysis start with a catheter access. So that is patients who come through the PEAK program.
Wow, that is much lower than 62% in all of Virginia. So I'm inquisitive. This PEAK program is predominantly CKD patients. We are trying to follow them longitudinally through focused education to prevent progression and or at least get them to appropriate modalities like home dialysis or transplant. Am I correct?
Yes, that's right. And we do try to emphasize those two modalities. So we've had a pretty good success rate of about 12.5% of patients getting preemptive kidney transplants, which compares obviously favorably to the USRDS, which reports about 2.5% nationally. And we've had about 20% of patients start home dialysis. Which is a reasonable rate, certainly not anything close to what the government was hoping for in the Advancing American Kidney Health Initiative, which I think set a goal of 80% by 2025. I'm not sure anybody in the country will reach those numbers, but we've had pretty good success at getting patients to start it.
No, I agree with you. At least the momentum is in the right direction, and the PEAK program definitely is something we want to learn more about. How do you select your patients to be in the PEAK program? And you mentioned focus education. I'm just curious, how frequently are you providing that education in a very busy climate where, physicians don't have but 20 minutes to spend with their CKD patients, that too every 6 months or 4 months. So how are you able to overcome those barriers?
Yeah, so there are a few interventions. In terms of selecting patients, we don't. It's all patients with stage 4 CKD or more advanced, and we reach out to them through different modalities. So we encourage the nephrologists to ask them to enroll, and our PEAK program will reach out directly to the patients. Typically, the nurses will call and ask them to enroll. In terms of the actual educational aspects of it, so it's really a nurse-driven program. And although the kidney disease education benefit doesn't adequately reimburse for their time, it's certainly easier to get their time than it is to get a physician's time. And so that's really been the emphasis of the program, is that it's not physician dependent.
That's good to know. And I think that adds to the value of team-based approach to our complicated patients. And they are complex with a lot of needs. And I like how you are providing this holistic approach to a very complicated CKD patient, so we can allow them to have patient-centered care and, live kidney disease with the goals that they have, whether it's dialysis or transplant or conservative management for that matter. But
Absolutely. And I agree with you that care of patients with advanced CKD, whether it's those who are not yet on dialysis or certainly those who are on dialysis, is very much a team approach, and does require collaboration among various different disciplines in order to provide the kind of care that we all seek to provide.
Well, thanks for sharing that your catheter rates are much lesser with these focused education plans. Just curious, do you also have a post-AKI clinic or something like a transitional start unit that would allow a smoother transition from acute kidney injury to dialysis?
So we do have a transitional start unit, which really serves a couple of purposes. One, it does allow us to monitor patients with AKI more closely in the dialysis unit in a dedicated space. And two, it allows us an opportunity to educate patients who haven't had as much advanced care education as our patients coming through the PEAK program have had, about transplantation and home modalities. And we can even bring out the home equipment to show them that it's not so intimidating. As you know, many patients are simply intimidated by the idea of doing dialysis at home. And when they see the newer machines and the relatively easy software that they have, it makes it a lot less scary for them.
Well, I know, and we've had our own experience with transitional start units in UVA dialysis, and the outcomes have been very positive. And again, it reinforces the fact that re-education of patients about all options allays a lot of anxieties and fears about home dialysis modalities and or transplant. So thanks for sharing about the CKD population and the acute kidney injury population. My question is, what do you do in the hospital for the folks that are crash starts or urgent starts? How do you educate them?
Yeah, it's much more difficult. For a while, we had a nurse practitioner who we employed specifically for that role. We actually called it Peak Light, and she would go and spend time and educate each of the patients. Unfortunately, she was hired out from under us, so we no longer have a person fully dedicated in that role. We do have a nurse practitioner who works on our chronic service, and she is able to spend more time with the patients and at least begin the educational process. It's not certainly as detailed as our outpatient program, so we do refer the patients back for further education after they're discharged from the hospital. We do also have a urgent start PD program in the hospital for patients who've been educated at least to some degree and think they're interested in PD. We've been able to establish a program whereby the nurses are educated in training patients and begin the training in the hospital. And then we get the catheters inserted and can actually start PD with low volumes within a day or so of the catheter being inserted. And that way, hopefully we can avoid putting in a VAS cath for hemodialysis and begin to train the patient and get them comfortable with doing the PD. So that's been reasonably successful, although it's a small number of patients who've gone that way.
No, but a very important point. Thanks for bringing up urgent start PD, because that is an option, which obviously avoids a tunnel catheter and all its attendant complications, whether it's infectious or thrombosis. And if the patient's goal was to be on peritoneal dialysis, we're doing the right thing for the patient. So thanks for sharing about, what we do for chronic kidney disease, acute kidney injury, as well as the hospital starts. Another question I had was, when we are transitioning them or discharging them from the hospital, what do you think are the safe care transition practices with regards to long-term antibiotics, whether it's new starts in the outpatient, or how do you combat drug level monitoring that should be communicated from inpatient to outpatient?
Yeah, so I think the word that you just used, communication, is the most critical word, and we sometimes don't do a great job of it. But I think that it's absolutely critical that prior to discharge, there not only be electronic messages that we've all gotten so comfortable with, but there actually be a verbal communication so that the person assuming care in the outpatient setting has a thorough understanding of, have the levels been monitored in the hospital? Are we comfortable that the dosing will provide the proper levels so that we don't, for example, if a patient has acute kidney injury, don't end up with a very high aminoglycoside level that might further reduce that kidney function or reduce the chances of recovery. So I think that communication is critical. Unfortunately, monitoring of antibiotic levels in the outpatient setting is very difficult. Most outpatient dialysis facilities don't have a hospital or a lab immediately adjacent, and therefore can't get laboratory values for antibiotic levels back in a rapid fashion. Most of the time, it takes more than the 2 days between dialysis treatments to get that level back. So therefore, dosing of the antibiotics almost needs to be done before the level comes back. So it's very difficult, and really that kind of adjustment needs to be done in the inpatient setting prior to discharge for optimal care.
Got you. And is there any role of having a multidisciplinary team involvement prior to discharge? For example, having a pharmacist review the discharge summary along with the nephrologist and the primary team before a handoff of care has happened to the nephrologist or the dialysis organization?
So I'm a big believer in antibiotic stewardship programs like you're describing, with a pharmacist as well as infectious disease people being involved, in addition to the primary care team, be that a hospitalist team or a nephrology team. I think that the collaboration goes a long way. The pharmacists are incredibly skilled at helping us determine the antibiotic doses. as well as ensuring that we've got the best antibiotics for a patient's particular infection. And obviously, if we can avoid drugs like aminoglycosides and vancomycin, for example, which have potential renal toxicity, so much the better for our patient.
I agree with you. And communication is the key. And in fact, it needs to be closed loop communication. What suggestions would you have for a home hemodialysis patient who may be admitted to the hospital with a bloodstream infection and now requires antibiotics in the outpatient setting? How should nephrologists or providers tackle a home hemodialysis patient and outpatient antibiotics?
Yeah, it's obviously a little bit more difficult situation. I truly believe that patients who do home hemodialysis can be taught to self-administer antibiotics, much the way we do with peritoneal dialysis patients. I think that the addition of the antibiotic to a solution, in this case, say 100 cc bag of saline or D5W, and then infusing it through the line that's already open, I think is something that most patients can learn. And I think that that's a better approach to it than asking the patient to come in center to get their antibiotics, whether that be to have their dialysis in center or simply to come in for the nurse visit to get the antibiotics.
Got you. And in our hemodialysis organization, we do educate our patients on home hemodialysis to be able to administer antibiotics just like they give themselves iron, but not everyone may be a candidate. And what also gets complicated is if they're doing short, frequent dialysis, then the pharmacist's involvement becomes more difficult because the dosing is a bit more intense. But can be tackled, but definitely complicated.
Sure, and obviously some antibiotics need to be administered with greater frequency, so it can be very difficult dosing at home, as you say, particularly for those patients who dialyze more frequently.
Mm-hmm. And what do you think is the role of MedRec reconciliation in providing safe care transitions in dialysis delivery?
Again, I think communication is essential. We find that often medication doses are adjusted in the hospital and the outpatient providers aren't completely aware of it. And that creates great confusion for patients. I've seen many cases, for example, where a patient may be on an ACE inhibitor at home and they get admitted to the hospital and that particular agent isn't on formulary. So the patient gets a different agent in the hospital and then gets discharged with a prescription for the new agent. So they then have two prescriptions at home for two different ACE inhibitors, and the patient isn't sure which to take. The outpatient providers aren't aware of the difference, so it can become terribly difficult. And so, again, I think communication is absolutely essential, and that list of medications, particularly new medications, needs to be communicated to the outpatient provider. And I'm a big believer, again, that it's not enough to provide electronic communication, that a phone call is absolutely essential to ensuring that the patients get the best care.
No, that's a point well taken, is to talk, a communication or a phone call would go a long way and antibiotics won't be missed. What other data products do you think would be useful that we could share back with our nurses or techs on the dialysis floor that could provide safer transitions?
So one thing that we've been working on is looking at at bacteria profile. So there are new techniques that will allow us to take, for example, a patient with a catheter and take the discarded blood and see what bacteria may be present in an individual patient's bloodstream. And that way, if that patient, or in that patient's catheter, I guess, and that way, if that patient does develop an infection, you can have an idea what bacteria they're likely to have and can use that to narrow your antibiotic spectrum. Still a little bit experimental, but a technique that I think is very exciting.
No, thanks for sharing that, because positive blood culture could be access related, it could be a contamination, or it could be something else. And knowing what are the top pathogens based on your antibiogram or the bacterial profiling that you mentioned could help tailor antibiotic choices for sure.
And we know that only about half of blood cultures done in the dialysis facility are positive anyway. So, we miss half of them. And so if we could pick up what are the more likely pathogens, it might help us quite a bit.
No, I agree. And could you educate the audience on what common problems they should look for in patients that would prompt them to have IV antibiotic starts in the dialysis unit?
Sure. So we know that not all patients who are on dialysis present with infections in the same way that somebody with a healthy immune system does. The data is pretty strong that the immune system of most patients who receive dialysis does not work as well as that of the general population, so that commonly patients won't present with fever, chills, diaphoresis, although when a patient does have them, those are very good signs. Clearly, gets down to the old discussion of specificity and sensitivity. So there's specific signs, but I don't think nearly as sensitive in patients receiving dialysis. And in our patients receiving dialysis, we find that things like changes in blood pressure are the best signs that we have. I think listening to the patient is critical. Oftentimes, a patient will tell us they just don't feel right, and they may not have specific signs, but that always, to me, heightens my suspicion that a patient may have infection. If the patient's symptoms change during a dialysis treatment, even if they just tell me they're feeling really cold, that can often be a sign of infection. And certainly if the blood pressure drops unexpectedly during a dialysis treatment. So a lot of times, particularly with patients who've received dialysis for a period of time, we get a pretty good sense of what their patterns are in terms of which patient drops their blood pressure more than another. And so if a patient who doesn't typically drop their blood pressure with ultrafiltration drops their blood pressure, that to me is a concerning sign for infection.
No, thanks for sharing all the issues related to, infectious complications and, cellulitis or exit site infection also is a nidus for a bloodstream infection. And not to mention, simple things like pneumonias and upper respiratory, which could contribute to other causes of infection. Is there a particular, top pathogen that you all identify in your dialysis units, or the most common ones that physicians should think about?
Yeah, so I think in most dialysis units, staph is number one when we look at catheter infections or access infections in general. As you say, those are skin pathogens for the most part. And so any patient with cellulitis or skin breakdown is most likely to have those pathogens. Certainly, we do see strep, both in terms of strep pneumonia as well as skin pathogens. We see a fair amount of enterococcus, particularly with patients who may have urinary tract infections, but also patients who've had antibiotics. We start to see a lot of vancomycin-resistant enterococcus. So those are the pathogens I think we see most commonly. And in patients with diabetes or patients who've received a lot of antibiotics, we see a higher proportion of gram-negative bacteria.
Thanks for sharing that. And how does one tease out what is a contamination versus access-related problem or other causes for bacteremia?
Yeah, so I was always taught that if you have bacteria growing in more than one bottle of blood culture or more than one set of blood cultures, you can be quite confident that that's a real pathogen. And certainly when you see unusual pathogens, particularly if it's a patient who hasn't had a lot of antibiotics or a lot of other medical complications, that would certainly make it more likely that it's a contaminant.
Well, thanks for educating us about what to look for that should prompt us to give IV antibiotics to our patients. We talked about transitioning from hospital to dialysis and home hemodialysis to in-center dialysis. My question to you is, what happens between dialysis facilities? Let's say someone is transferring from New York to Virginia and they're requiring antibiotics, and I do not have the antibiotic that your institute was giving. And what should we do when they're going between peritonitis from PD to in-center and are, changing modality. How could we ensure safe transitions?
Yeah, so I think for all transitions, much like we talked about with the hospital to outpatient transition, communication is the key. And again, I think it needs to be a phone call between different providers, so that if my patient is coming down to visit with you, I would give you a phone call and say, this patient has Staph aureus or whatever else it is growing. We've been treating the patient with antibiotic X. If you tell me we don't have antibiotic X, it would then be worthwhile taking a look at the antibiogram to be sure that the bacteria that are growing are sensitive to the antibiotics you do have.
Thanks. And what about a PD peritonitis patient who still has a PD catheter and could be dialyzing in-center? What could we do to salvage that catheter while getting treatment for in-center dialysis?
So I think that even if the patient isn't terribly symptomatic, that providing a full course of antibiotics through the PD catheter is essential to preserving the catheter. I think that untreated infections not only can cause issues with the catheter in terms of causing it to be recurrent or permanently infected, but can cause inflammation of the peritoneum itself that can make dialysis very difficult. I've seen ultrafiltration failure and poor clearance as a result of peritoneal inflammation. So I think preservation of PD requires that full course of antibiotics to be sure that the infection is fully treated.
Thanks for sharing that. Any last pieces of advice for dialysis organizations or providers? I've heard wonderful things from you with regards to dedicated educational programs, closed loop communication between providers and the entire team taking care of dialysis patients, the role of antibiograms and, bacteria profiling to stay on top of resistant bugs versus sensitive bugs. Anything else we should be looking at or that is unmet that would be needed for safer transitions?
So two things I would say. One is that physicians always have to assume the mantle of leadership in a dialysis center, and have to always remember that everybody is watching the physician as the physician makes rounds. So the physicians have to be really sure they're doing their hand hygiene and all of the other infection prevention activities that we're all so well aware of. Because if the physician isn't doing it, then it's going to be that much more difficult to convince the nurse or the technician or the patient to do their own hand hygiene. So I think that's critical. And the second element is to be sure that we as providers, and this is true of physicians, nurses, or anybody else in the dialysis facility, take all of the appropriate infection prevention actions that we can take. So hand hygiene, washing your hands if soiled, using a mask, particularly if either you have any upper respiratory symptoms or if you're going near a patient whose catheter or vascular access is exposed, wearing a gown, and particularly an impenetrable gown when cannulating an access. I think it's critical that we all remember that we carry bacteria, no matter how careful we are, on our skin, on our clothing, and in our nares. And if we don't do everything we can to prevent those bacteria from getting into our patients who are more susceptible to infection than we are, then we're not helping our patient.
And that's a very important point that you bring up. And so thank you for giving us those words of wisdom with regards to being role models in our dialysis units about infection prevention.
My pleasure.
Thank you, Dr. Silversberg. I appreciate you taking time to share your expertise with regards to safer transitions between hospital and dialysis units and in between dialysis units. We'll look forward to more podcasts with you.
I enjoyed being with you today, Dr. Chopra. Thank you for bringing this important topic to our colleagues.
Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.